Thank you, everybody. So it's my real pleasure to introduce our keynote speaker, who is Gillian Prue, Dr. Gillian Prue, should I say, who is a physiotherapist and a reader in chronic illness from the School of Nursing and Midwifery at Queen's University, Belfast. Gillian's going to talk to us about future directions of cancer research. She's got quite a good bit of experience to draw on. She's interested in cancer prevention, survival, and the reduction of cancer-related symptoms. And she's been involved in various exercise studies, including the Global November study in advanced prostate cancer and the STEALTH study on physical activity in adolescents. So, Gillian, over to you.
Just realised there I was still muted. Thank you very much. Okay, so yeah, great. Thank you so much for this invitation to speak today. Whenever I was talking to Nicola about sort of what I would talk about, we thought it might be nice to kind of, if I just spend the first few minutes of the presentation talking about sort of my career and my research interests, and then I'll move on to talking about sort of COVID and the impact that COVID's had on sort of living with and beyond cancer research. I've got some positives in there too. I had a little think about those, and they're probably going to reflect also what Kim's thoughts were around what some of the positives were with COVID and research. And then I had a little think, and I thought to myself, okay, what do we think are the future directions, and what, you know, from the impact of COVID and the impact that's had on patients and treatments, and what would be my thoughts around maybe the directions that we should be looking for cancer research. I very quickly added this photo of Queen's onto this slide when everyone was talking about their lovely areas of Wales and where they were from. So this is our nice Lanyon building at Queen's University in Belfast. So if anyone ever gets the chance to come over, it's definitely, even if it's not work related, if you're coming over to Belfast for a weekend, you absolutely have to come and see the Lanyon building. It's a beautiful building that us normal academics aren't allowed into. I think if you get caught, if you're ever in the Lanyon building, that means it's either a very special event or you're in trouble. It's one or the other. So yeah, it's absolutely worth visiting. Okay. So a little bit about me then. So I bravely put the dates on the slide. Kind of initially didn't, and then I thought, no, we'll put the dates on these. So back in the early 2000s, I completed my undergrad degree in physiotherapy at the Ulster University, and then kind of moved on very much to study a PhD in cancer-related fatigue. That kind of came about from when I was an undergrad and I was at a placement in what was the Beaver Park Cancer Hospital in Belfast before it all amalgamated into the Northern Ireland Cancer Centre, and meeting a lot of different patients. I really enjoyed that placement. I really enjoyed working with people with cancer. I kind of felt from a physio perspective that every day was very different, and all the patients that you saw were very different. It depended on, you know, where their tumour was and what issues they had, and I really enjoyed that. So there was a PhD that was advertised in cancer-related fatigue. It wasn't my career, and the way my career's gone was never something that I anticipated. I thought I would kind of just be working out in practice, but this PhD was advertised, and I took up that opportunity to do that. I was then very fortunate to work with the late Professor Eilish McCacken in Ulster, doing some postdoctoral work with her on a lot of different men and cancer projects, and that's what got me involved in prostate cancer, and then working with men's health as well, which I'll come back to in a second. I ended up having this interest in men's health as well. After that then, so I joined Queen's University in 2012, which sort of scares me a little bit when I think that's now nearly 10 years, which I can't believe where that time has gone. So I've almost been there 10 years now, which really is unbelievable that time has passed so quickly. Sort of what would make sense, I suppose, for my PhD being in cancer-related fatigue, I very much always just stayed in that area of research, and I sort of work in what was called, I suppose, supportive care. Sometimes it was called survivorship care, and recently it's been called living with and beyond cancer. I do lots of different types of projects, but I suppose the vast majority of them would probably be exercise related, whether it's rehab or prehab, and then sort of multimodal interventions where we're now beginning to learn an awful lot more of how to sort of combine exercise, nutrition and psychological well-being into our interventions, and really do that properly alongside a behavioural component as well. So I think that's probably where a lot of the work lies at the minute. The other little bit I thought I was mention is HPV vaccine for boys, and it's so different to the other work that I do. It came around from working in men and cancer, and I got involved in the Men's Health Forum and then got involved in an HPV action group. And the reason I mention it here is because we worked hard and we lobbied the government and we eventually got boys vaccinated, but that's kind of the aside, because obviously we're talking about research and that was more policy and lobbying. But it's sort of a bit of advice that I always tell everyone: don't be tempted to just put yourself in one box, because you've got plenty of research skills that can be transferable to other projects. And just, I mean, I never would have thought I'd be working in vaccine research, but we kind of do a lot around vaccine perceptions and vaccine hesitancy and sort of encouraging vaccine uptake. So yeah, it's just to say that sometimes you can do something a little bit different, and you do have the skills as well to be able to contribute to that. So then we thought we'd sort of look a little bit about hints and tips on how to develop a career. And these, I say, are just some of the ideas and thoughts that I had when I was putting together this presentation. I think sort of Jane had mentioned this at the start about sort of small projects and very local projects. And these were really useful to me in the early days when I was sort of first working in Queen's, because we were in the university and we didn't have those direct contacts with the people that actually know the issues and are on the ground working in the cancer centre. And sort of small projects and integrating well with the cancer centre and with those healthcare professionals has been invaluable to me. That, you know, they get to know me and I get to know them, and we have a really good relationship, and it's really definitely helped get research off the ground. And also, if you can, I think PhD supervision is really useful, and that's very much how I had started to sort of learn the ropes and get involved again in those sort of smaller projects. I think that's a really useful path to take if it ever is presented as an opportunity. I thought, since this was a Wales Cancer Conference, I would pop in a little bit and about challenges of research in a devolved nation. I do sometimes feel it's difficult, particularly I can speak from a Northern Irish perspective. Research funding is not always available in Northern Ireland. We don't have the same opportunities to apply for some of the grants. We can't apply for research for patient benefit, for example, as one of them. And for many years, we didn't have access to some of the other NIHR funding calls. Now we do, but still not research for patient benefit. And I suppose one of the ways to overcome that is definitely about connections and collaborations. And I cannot recommend that enough for anyone who's starting a career in cancer research, who's developing their career, is to join everything or anything that you have the opportunity to join, because it has made a massive difference to me. I joined the National Cancer Research Institute whenever it was the Supportive and Palliative Care, CSG. And I would say for that, I wasn't long into Queen's at that stage. And I think for the first couple of years, I just listened, I just learned, and you learn so much about how to run studies, how to sort of connect centres, how to run large multi-site studies, and you learn so much about networks and about the research nurse roles and how everything works, that it was just invaluable. So I really recommend it, and I've sort of moved on and now sit on the NCRI Living with and Beyond Cancer Executive that Jim had mentioned. And again, it's just been wonderful for making connections and collaborations and setting up projects. I'm also in, as I said, the Men's Health Forum in Ireland, and also Global Action Men's Health, which again has really helped sort of promote the research. The one other that I wanted to mention is the November Foundation, because I think this was one of the big turning points for me in my career. They offered, it was called GAP4, which Nicola mentioned at the start, which is an exercise study, a global project for men with very advanced prostate cancer. And I had the sort of opportunity to to be a site for that and to run that in Belfast. And that was a really nice way to get involved in a large trial without the stress of sort of everything being on your shoulders, because we had the project was written, the proposal was written by people in Australia. and it was run by sort of had oversight in the States. So you kind of were learning how to deliver these projects without having to worry of actually delivering, you know, the kind of the high level, all the other stresses that I have learned that come with that. So sort of getting involved in that has really made a difference. And this project, it looks at sort of HIIT, so high intensity interval training for men with very advanced prostate cancer, metastatic castrate-resistant prostate cancer. And I put it in here because it's one of the things that I said about collaborations and getting to know your local contacts, because whenever I sort of first heard about this study and I went to talk to the prostate oncologists about how we were going to recruit men with very advanced metastatic prostate cancer, and we were going to get them to do high intensity interval training. Initially, I thought I would be met with an awful lot of resistance to it, but because they knew me and we had that relationship, they were very happy to support this project. And as I say, it has been great to be involved in that. And it's fascinating because what we're actually looking at is, does a high intensity training actually impact overall survival? So it's brilliant that we know how exercise can really help with quality of life, with symptom management, but now we're actually looking at the survival benefit. This came about really from a number of epidemiological studies that had observations about how men post prostate cancer, if they exercised quite vigorously, it improved their survival. They seemed to live longer than the men who didn't engage in so much exercise. So now we're looking at that from an actual experimental perspective. And I just thought before I sort of moved on to the COVID bit, I would just sort of mention some other projects that I'm involved in that are exercise oncology studies, and also obviously to mention this another sort of way and how we progress and get and be able to do, you know, to do well and deliver studies is obviously with our postdocs as well. And I can never do a presentation without mentioning them. And I'm very fortunate to have 2 exercise physiologists who work with me to deliver a lot of these exercise trials. Dominic has recently moved to Nottingham and it's sort of left a big gap there, but Malcolm is very much doing well and filling that gap. We run another prostate cancer exercise trial called Exact, which is for the same population as GAP4, but it's more moderate intensity home-based exercise, really for those men who were ineligible for the HIIT training. We wanted to still be able to offer them something, so we offer them, see whether or not they want to take part in that. And also we've got a Pancreatic Cancer UK funded study called Precise, which came out of my involvement with the NCRI, that we're looking at exercise for people with pancreatic cancer after their Whipples while they're having chemotherapy. And I'll talk in a second about COVID and how COVID has impacted these studies and how we've been able to continue with those studies. Okay, so now we'll kind of think about this, and we'll think about COVID and living with and beyond cancer research and the kind of impact of that, and the sort of recommendations and where we think future research should go. So I suppose there's been, for me, there's really been an immediate impact, obviously with COVID, that if many of you have been involved in projects have probably had similar impact. There's very immediate, and then there's sort of what I anticipate that we will have impact be seen for many years to come that will very much influence the research that we do. The very immediate impact was obviously recruitment. Obviously it's initially everything kind of ground to a halt. Because we were based in Queen's, we very much relied on our postdocs being embedded in the cancer centre and being at the clinics to be able to recruit, and suddenly that stopped. Obviously the research nurses and everything were pulled to other different tasks as well. So recruitment initially stopped. We then had the challenge of when trials were starting to reopen again, we were recruiting in a very different way. We had to learn and put in ethics amendments to be able to recruit online, because that wasn't part of our sort of protocols initially, and we had to learn quite quickly how to do that, and how to, if the oncologists were running online clinics, how do we make sure they remembered to mention to a patient about a potential study when they didn't literally have our face in their faces all day long at the clinics. So we sort of had to look at that in a different way. Delivery as well. So this has been, and I'll come back to this, I think is one of the positives, because particularly from our exercise trials and other psychosocial interventions as well, I'm sure, we sort of have learnt how to change delivery and delivering online where we can. And I think that's been quite positive. We've been able to look at some of the exercise interventions online with sort of online supervision, so that, you know, the exercise physiologist would set up a Zoom call or something, but obviously always making sure there was a carer or someone in with the patient whenever they were doing their exercises and things. We had to put in a lot of risk assessments to allow us back into the gym once the gym actually was allowed to be reopened, and make those changes. But we now have our pancreatic patients are back in the physio gym currently for the trial, which is great. In the future, then, the sort of impact, obviously, I mean, everyone's going to know and understand this. There's been huge delays in diagnosis, delays in starting treatments, changes in treatments, sort of issues with continuity of care, with follow-up, long-term sort of late effects. All of those things have been impacted, and we really need to look at this and look at what we need to do in the future with the research to address a lot of these problems. And I come to that in a second. I've got some suggestions of potential projects and ideas that I think would be really useful. So the European Cancer Organisation has sort of started with this, and I was at this meeting when they were talking about cancer in Europe and the impact of COVID. I just thought I'd pop this up because some folks might find it interesting to look at how they sort of, as they've called it, building back better. It's not just specific to living with and beyond cancer work, but I think some of the points really are. Some of them are just looking at our delivery of cancer services and addressing the backlog, looking at how they sort out medicine shortages, PPE equipment shortages, and looking at the workforce in general. But they also look at this idea of employing innovative technologies and solutions to strengthen cancer systems and provide optimal care. And I look at this in a second about one of the sort of research ideas and what we can do in the future around sort of telemedicine and things like that. Yeah, and then they have a couple of other sort of points around you know, data collection, cancer intelligence, you know, all these different things. We hear so much about the digital world and how they can better improve that. So if anyone is sort of interested in it, you can access that quite easily. They have this document where you can read and how they're thinking about addressing a lot of the problems that they've seen from COVID. So I had a little think about this, and as I say, I thought, well, I can't just be completely negative. So I thought, let's think about some of the positive impacts that we've seen on our research. And I say that I was pleased to hear that Kim had sort of reflected some of these. So sometimes I think, because I'm not really back in Queen's at the minute, and I think sometimes am I just sitting in my little office at home writing these things, and so it's nice to know that others are on the same track as well. I think, as sort of Kim had said, we definitely have this new culture of conducting research and that sort of fast collaborations that we set up in response to COVID calls, multi-centre working, online working, I think has made a huge difference. It's made a huge difference to me being based in Belfast that, you know, all the meetings and everything that we have are online. I no longer am, you know, on a flight a couple of hours and travel for a 1 hour meeting in London to then fly back home again. So that has made a massive difference. And one of the examples I can use of how this kind of COVID has made a really positive impact is pre-COVID. I spent a week in Bogota in Colombia because we were looking at collaboration opportunities. And when I got home, we got some more funding to kind of go back out to Bogota and spend a week, sort of a week-long workshop working with everyone in sort of Colombia, bringing everyone together who had an interest in living with and beyond cancer research, bringing them in a room. Do you know, how do we sort of think about research ideas? How do we take projects forward? And that obviously couldn't happen because of COVID. We couldn't go, and we thought, right, what are we going to do? We have this money. And what we actually did in the end was use the money to build a website and ran an online extended workshop, so to speak. So we started in March 2021 and we extended it right through until the end of June this year. And we ended up having about 70 to 80 people involved in this. We had an initial big sort of opening meeting with everyone and a meeting at a closing meeting. But in between time, people went into working groups of their own sort of topic interests. So whether it was palliative end-of-life care, whether it was people that were interested in mental health, people that were interested in physical activity. And rather than cramming everything into 1 week, COVID and this model gave us an opportunity to actually meet each other online for an hour every week, every other week, and develop collaborations, develop relationships, and start writing protocols. So we actually have a number of projects and things that have come from that, from a very small amount of money that really was only to just take us to Colombia for a week. So I think there are some positives in that, and I think we should definitely always look to keeping going and working in this sort of virtual environment that we have got so good at. Of course, you can't underestimate the face-to-face, but I think it has opened up a lot of opportunities that weren't there before. As Kim obviously mentioned, the hope about less governance and faster ethical approval, it's like the holy grail of research, I think, sometimes. Fingers crossed that we might see that come to fruition, who knows. I also think that it's been quite nice, and for me personally as well, is that idea of being adaptable and very pragmatic and being flexible in our interventions, because sometimes we were so strict in a trial, and rightly so from a methodology perspective, but what we're learning now is to be a little bit more flexible, a little bit more real world potentially, and useful in those interventions. Now, obviously there's two sides to everything, and sometimes we have to be very strict from an efficacy perspective, but there's other ways I think that we have to adapt to the times we're living in, and we have to be able to to be able to continue to deliver trials in that way. And the virtual environment that I've mentioned a couple of times, obviously then we adapted our exercise trials for people to work online, and I wouldn't have thought pre-COVID that a lot of that was possible, but a lot of our participants got more confident in using technology to sort of connect with their families, and I just think that really it's a massive positive that we now have this resource and people that are happy to sort of connect in that way. So I had to think about the different questions, and I thought there's big questions and then there's more small sort of specific questions, and I suppose the kind of big questions which are too big to answer, but they were just kind of my thoughts in general. Can things be learned from practices where people manage to retain cancer services, and what can we learn from that? And also obviously to really look at the impact of the pandemic of all elements of cancer care. So not just look at the impact of from diagnosis and sort of looking beyond the chemotherapy and radiotherapy, but looking at all the living with and beyond cancer elements, the psychosocial care, but also the sort of palliative and supportive care as well. And what I've done then is give some sort of specific thoughts, and these are just my thoughts, and I'm sure everyone has their own thoughts about what needs and could be done. As I mentioned previously, I had to think about sort of telemedicine and innovative technologies, and what can we learn from that? And these are just some thoughts I had on research questions. So obviously clinics have moved virtual for in a lot of cases. What's the impact on that on the patient themselves, on their quality of life, on their symptom management? Do they communicate as well? And how do they feel about those clinics? I'm sure there's lots of work that's probably ongoing at the minute and could be done on that. And what are the preferences for patients moving forward? Would people prefer to have virtual sort of online clinics? Is there some sort of idea around hybrid models, sometimes face-to-face, sometimes online? We've got to be really careful that we don't further increase inequalities in access if there are people who are less able to access, and can we identify those people? Can we predict that who might sort of need more assistance with that? Along the same line that I had spoken about earlier around telemedicine and delivering interventions. I mean, I think this has been great because we've been able to deliver supervised sessions. But then how does this impact on who we recruit and the population that we recruit? Because, I mean, there's a criticism of exercise projects all the time, which is perfectly valid, that we only get people who probably are quite fit previously and quite keen to sign up to an exercise program. But what does the impact then of an online session have? Does it increase participation for some people, because we would have been asking people to travel from all over Northern Ireland up to the cancer centre for a supervised session? do these sessions work as well? Do you know, there's so many, and that's not just specific to exercise, that could apply to any intervention. A big one I think to consider is probably the impacts on families and informal carers. I've spoken to a couple of colleagues who kind of work very much in this area, and these were kind of some of the ideas and thoughts that they were having and what they've been hearing from speaking to some of the carers. From the healthcare professional perspective as well, this idea of this empty chair and sort of in the appointment, that the carer was often a resource to the oncologist or to the clinical nurse specialist or to the physio or to whoever they had the appointment with on how the patient was coping and what their symptoms were really like. And that support's obviously been lost to the patient as well. And the impact then on the carer themselves from not being into those appointments. Has there been more of a burden on carers because there's been less support to them externally because of COVID? All the issues and impacts around keeping a patient with cancer safe sort of during COVID, and we're kind of looking at that at the minute in another project that I'm involved in that sort of looks at, it's an online support for carers, and we've been very much talking to carers about that and the impact of it. Of course, one of the massive ones I think is the psychological impact on patients with the delays in cancer diagnosis or potentially poor prognosis, changes in treatments, all of those things I mentioned earlier, and what sort of impact will that have on them. One of the other ones that I think is really interesting is sort of long COVID, and that's kind of raising the profile of late effects of other diseases that maybe potentially weren't as talked about as much, we didn't really think about them so much. I obviously did from a cancer fatigue perspective, but so it's just raising that profile. And is there things we can learn from long COVID fatigue that can help us in understanding cancer-related fatigue and vice versa? You know, there's lots of crossovers and lots of things that we could do that may help in that understanding. And the last sort of one, I think it's more of a challenge. There's potentially probably even less funding available for this type of research than ever before. This is an old slide, but I thought I'd pop it in here. This is from NCRI, so all the partner funders. And I remember the first time I saw this slide, and I always use it to just kind of highlight some of the inequalities around research for living with and beyond cancer. So the sort of purple is the total spend for biology, and the blue is the total spend for treatments. They're well over 200 million. Whereas we've kind of got this little bit here that you can't really see some of the bars, but it's we're talking about 9 million even for sort of patient care and survivorship. And I mean, we rely on an awful lot of charity funding, and a lot of that charity funding isn't available at the minute because charities have been hit hard by COVID. We also have been hit by sort of the overseas development aid, the global challenges research funds, all of that funding has been cut as well. So we didn't have much funding. I think we even have less funding, but I didn't want to sort of end it on a negative. And I thought, well, how can we fix that? What can we do? And I know this isn't easy, but I think it's how we've got to be thinking for projects moving forward, is working together more. And as I said, getting involved in those types of networks like the NCRI or plenty, I'm sure there's plenty of others, sort of helps with this. And when a funding call comes out that's specific to our area, rather than everyone going for sort of small scale, local, single center studies, we need to be working better together, and we need to be collaborating better together to have a nice, properly powered, designed, multi-center trial that's really going to answer the questions properly, so that whenever these funding calls come out, which they have, which has been nice, because the NIHR did have a living with and beyond cancer specific prehab call recently, but that we're in a nice position to be able to apply for these in a sort of large, nice, across all 4 nations, everyone included, fabulous project that will get funded. So those are just some of my thoughts on that. I know that's not easy though. So there, that's me. If anyone's got any questions, I'm always, my email's there. I'm always happy for people to get in contact about anything at all. Just give me a shout and let me know. And that's my Twitter as well.
Thank you, Gillian. That was great. I think it kind of, seeing a bit of your, dare I say it, the word journey, just highlights how researchers, people getting involved in research, it's often more of a meandering path than a particular plan. Certainly was the case for me anyway. I think we've got time for one or two questions. Jane, question from you.
Yeah, Gillian, you recommend joining various kind of groups, organisations, committees. I think you're absolutely right. It kind of opens up the world of possibility. However, the time involved, how do you manage your time? I mean, there you are, Queen's Belfast, and signing up to be part of an NIHR group and other networks. How do you do it?
I think it's one of the, when I said, I suppose initially I felt like the time I was putting in, it wasn't getting a lot back, as I say, from the first couple of years, but that I think it's so important just to learn and to be involved. And then all of a sudden you see the benefits of being involved in these things, and you start to develop the relationships and the collaborations and get the projects to start moving. So I mean, I'm fortunate probably because of I'm in a university, so I have not had huge amounts of teaching commitments, no clinical commitments, so I'm practically 80% of my time's academic. So a lot of involving in those groups and committees would be part of my, sort of day-to-day job. So I didn't feel like it encroached too much on my time. In that respect, it was more, I don't miss the 4 a.m. flights or whatever it was at a time to get to them. It's been great that these things are online now. An awful lot more opportunities have opened up, I think, because things are now online.
Okay, thank you.
Anything from anybody else?
I noticed Jim has just shared his Twitter handle about public involvement.
Yeah, great. I guess one other question which sort of sprung to my mind, Gillian, in adapting to the COVID situation and starting to deliver things online, did you feel like it impacted upon the study? Obviously it did in many ways, and that could have gone either way. Greater preference for doing home-based stuff, reduced traveling time, but then maintaining the intensity of the exercise, all of that stuff. What was your gut feeling on that?
Yeah, I mean, I think we did a bit of a survey with Macmillan Move More in Northern Ireland, so that they sort of Macmillan's physical activity program, that they sort of move a lot of their work online. So we kind of did a very quick survey of their members to see what their thoughts were around exercising online before we kind of totally shifted. Now we've shifted back to the gym because it's a pancreatic cancer patients. I wasn't terribly comfortable with it. I think different patient groups might be more suited to it because these were post-Whipples, really. I mean, we don't start their exercise till cycle 2 of their chemo, so we know they're settled and they're not unwell, and the consultants are happy about it. Now, some of them did transfer to online, but Dominic, who was the exercise physiologist delivering it, always made sure someone else was with them at home. He just didn't feel comfortable. Obviously, that was part of the risk assessment. We wouldn't have had people exercising on their own who had such a brutal sort of operation and things as well. And it was feasibility. It wasn't that we'd had hundreds of people through and this was a trial, and we were very confident that people could do the exercise. So it kind of half stopped as well because the surgery stopped for a bit. So we kind of didn't have a huge amount of patients coming through, and it's now back to the physio gym. We're really fortunate that as part of GAP4, the Movember study, I got some extra money to kit out our physio gym with a lot of decent sort of resistance training equipment and things, and the physios were lovely in the hospital too. They were more than happy for us to kind of put all the equipment in there, and they've been great. So they are back in the gym. So it's a very long-winded answer to your question. I think for pancreatic, I didn't feel terribly comfortable, but it was okay. I think for some other patient groups, say prostate cancer, for sake of argument, that were relatively, well, I think sort of the home-based exercise is perfect for them. That's definitely what we heard from Macmillan, the cancer charity, in their Move More group, that the women with breast cancer or the men with prostate cancer sort of post-treatment that were going to exercise sessions anyway were more than happy for those sessions to be delivered at home, and they kind of felt safer in their own home as well from a COVID perspective, I guess, you know, rather than being in a poorly ventilated room, everyone together.
Yeah,